Hello, everyone. Welcome to our session on kidney disease testing of the past, present, and future. My name is Julie Wright-Nunes, and I'm looking forward to being a moderator and speaker during this talk today. I'm a kidney doctor and a researcher at the University of Michigan in Ann Arbor. And in addition, I've been involved with the American Kidney Fund in many capacities, including as chair of the Medical Advisory Committee, chair of the Clinical Scientist in Nephrology Program, or CSN. I was myself a fellow in 2009 to 2011, and I'm vice chair of the American Kidney Fund Kidney Patient Education and Outreach Committee. And I'm delighted to be the moderator today. I'd like to introduce our other panelists as well. First, we have Dr. Alison Potok. Dr. Potok is an assistant professor of clinical medicine at the University of California, San Diego. She is currently funded by an NIH Career Development Award. For her training, she pursued her medical education at the University of Paris and completed a residency in internal medicine at the University of Pennsylvania Health System. Dr. Potok was a CSN fellow from 2019 to 2021, and she completed her nephrology fellowship at the University of California, San Diego. Her research focuses on understanding the reasons why serum creatinine and cystatin C may provide different estimates of kidney function within the same individual. And she's also interested in tools used to predict the progression of chronic kidney disease. We also have with us Dr. Inker. Dr. Inker is a professor at Tufts University School of Medicine, an attending physician in the William B. Schwartz Division of Nephrology at Tufts, and medical director of the Kidney and Blood Pressure Center at Tufts. Dr. Inker's primary research interests are in kidney function measurement and estimation, alternative endpoints for clinical trials of kidney disease progression, and epidemiology and outcomes related to kidney disease. We're very excited to have her and Dr. Potok join today's discussion. And Dr. Inker also was a member of the National Kidney Foundation American Society of Nephrology Task Force to reassess the inclusion of race in diagnosing kidney disease. So before we get started, I want to encourage all of you to please type in your questions and comments into the window next to or below the Facebook Live video stream, or in the chat box to the right if you're here with us on Kidney Action Week websites. We'll try our best to get to your questions during our question and answer segment at the end of the talk. So to start us off today, I'd like to provide an overview of some definitions, terms, and some of the challenges we faced in testing for kidney disease. We can go ahead and start the slides. So I'm going to start out talking about the past. Next slide, please. First, I think it's important to go over what the definition of chronic kidney disease is, or CKD for short. Chronic kidney disease is one term, but it encompasses many causes. It means the kidneys do not work or do not filter like they should. Chronic means kidney disease does not go away. It may for some get worse over time, and a person may be able to prevent the onset of kidney disease or slow the progression. Next slide, please. Kidney disease impacts many people. There's estimated to be 37 million people in the United States who have kidney disease. That's up to 15% of the population. Diabetes and high blood pressure are big risk factors for kidney disease, with 1 in 3 people having diabetes or 1 in 5 with high blood pressure that are at risk for kidney disease. 1 in 2 people aged 30 to 64 may have kidney disease as well. And in addition, people may not feel or know that they have kidney disease because symptoms don't arise until later in the diagnosis. So many people are unaware they have it. Here we're seeing some of the risk factors for chronic kidney disease, including diabetes and high blood pressure, heart disease, having a family member with kidney disease, also older age, and individuals who are Black, Hispanic, Native American, or Asian Pacific Islander may be at risk. Next slide. So why does chronic kidney disease matter? I think first it's important to understand all that the kidneys do. So this is a summary slide of all of the functions of the kidneys. The kidneys are remarkable in that they keep our blood cell production up, which keeps us from being anemic. They're important in bone health and keeping our blood pressure under control. And importantly, excreting wastes out of our system and making sure there's a good fluid balance. And it does this, the kidneys do this by filtering the blood. And in a way we understand how good the kidneys filter blood is by assessing the the glomerular filtration rate, or GFR for short. Next slide. So how do we know when a person has chronic kidney disease? We can use different tests. We can use urine tests to see if a person has it. We can test for something called proteins or albumin in the urine, and if these get too high, that can tell us that a person has kidney disease. We can use blood tests, and we can use collections of both blood and urine that are timed. Next slide, please. Specifically, there's different ways to measure how kidneys filter, and we can measure urine over timed collections to get estimates of this. We can do collections of blood and one-time measurements as well. Next slide. But most often in routine clinical practice, we'll use one-time estimates of blood work. So we can get blood work that shows serum creatinine. Creatinine is a breakdown product of protein that we eat in muscle metabolism, but it can change. It can change depending on our muscle mass, our diet, our nutritional status. We can also use this creatinine measurement into an equation that's called estimated glomerular filtration rate. And that tells us an estimate of how good the kidneys are filtering. In the past, we've used RACE in the estimating equation. And again, this is based on a one-time blood test. Next slide. That's kind of a quick synopsis of some of the past and some of the general terms related to kidney disease. And now we're going to re-invite Dr. Inker to talk to us about all of the work that she did with the National Kidney Foundation and the ASN Task Force, recently reviewing some of the challenges testing for kidney patient function, or eGFR, and we're delighted to have her here. Just as a quick note, if some of you are just joining our session, we'll have questions and answers at the end of the meeting time today, but you don't have to wait until then to ask your questions. You can put them in the comments window next to or below the Facebook live stream, or in the chat box right next to the Kidney Action Week website. So, Dr. Inker, since you are a member of the task force, can you share with us the process and what led up to the changes and how it suggested we report eGFR, and specifically the discussions and decisions removing a factor of race that had been in these estimating equations?
Sorry about that. That's also official. I thought you would unmute me. But hopefully you can all hear me now. And I'm really delighted to be able to talk to you all today. Next slide, please. So I often get asked the question is, why was race included in the estimating equations in the first place? As you just heard, we actually measure something in the blood called creatinine, but creatinine can be changed depending on various things in our bodies, such as our diet and our muscle and other factors. And so we use, which we can't measure, and so we use surrogates for these unmeasured factors to estimate the actual GFR, or the glomerular filtration rate. And the most common factors were age and sex, and what was observed to be race. So here's a figure from a study called the MDRT study, which tried to evaluate whether eating a low protein diet or treatment of blood pressure would help progression of kidney disease. And they took the opportunity of that study to also measure GFR using a gold standard measurement. And what the investigators observed is that for Black men or Black women had higher levels of creatinine compared to white men or white women for the same level of measured GFR. And so the investigators decided, let's include a term for Black race just to make sure that we can get the most accurate estimate in all people. Creatinine itself doesn't have the implication of health, it's the GFR value. And so providing an accurate estimated GFR or accurate GFR value for everybody was the best way they could think of leading to best care in all people. Next slide, please. And in fact, this was consistent with other data that were available at the time. This is data from a population health survey taken in the United States called NHANES, or National Health and Nutrition Examination Survey. And what those investigators showed, and this is a different group of investigators, showed that across all ages, that Black men had higher levels of creatinine than white men, and Black women had higher levels of creatinine than white women. This was just an observation, but it confirmed the observation that we had made that was made in the MDRT study. Next slide, please. And so for a long time, the equation was used in practice, because it provided the most accurate estimate of kidney function, of GFR. But in the past, about 3 or 4 years, there's been questions about whether this was wise. Race, as we know, is a social construct, and that's going to change over time. And so even if it was the right decision way back, it may not be the right decision now. And this is an article published in June 2020 by now one of a close colleague, Dr. Anyanye, who asked the question, should we reconsider the consequences of using race to estimate kidney function? Next slide. And that really set off a lot of conversations, a lot of people, but it was only in June 17, 2020, that really got the attention that so many people were asked. And this was published in the big medical journal, the New England Medical Journal, asking a big question, hidden in plain sight, reconsidering the use of race correction in clinical algorithms. And they used GFR as one example of algorithm. They needed to be changed now because of the inclusion of race. Next slide. So we then came along and said, okay, we hear the questions. It's a really good question. What are the consequences to individual people if we simply drop the term from the equations right now? And so let's just pause and say, okay, how did removing race impact the calculations? And I have 4 individuals here, patient AB and patient XY. Patient AB is a 65-year-old female with a creatinine of 1.1, and patient XY is a 65-year-old female with a creatinine of 1.9. And so day 1, we compute the GFR as was the original equation that includes the term for Black race. And day 2 will be after the race term was dropped and when they commute the GFR, ignoring the race coefficient. So we looked at patient A, and she's somebody who self-identifies as Black. And our day 1, her GFR will be 61. And the next day will go down to 53. Not because there was any change in her creatinine, not because there'd be any change in her kidney function, which of course is what we're most interested in, just because the term was removed. Next slide. In contrast, slide B, who self-identifies as white, her kidney function did not change. Next slide. And now we have patient X, whose creatinine was higher, same age and sex, and this person, patient X, identifies as Black. The day 1, the GFR was 32. On day 2, after dropping the race term, it goes down to 27. And next slide. Patient Y self-identifies as white, and again, there's no change in the GFR. The question we need to ask is this good or bad? It may be a value, but it may not be. And what are the potential benefits or harms? Next slide. So potential benefits are, well, you'd have more diagnosis of kidney disease. If your GFR was 61 on day 1 and went down to 53, you'd actually be diagnosed with kidney disease. And that might engender a lot more attention by your doctors to the care one would need for having chronic kidney disease. Faster referral to specialists, faster access to transplant waiting lists, especially when you go at much lower levels of GFR, increase access to Medicare services, where for patients with GFR less than 30, you can actually get a nutrition and education consult for chronic kidney disease, and overall more aggressive CKD management. And that was some of the arguments that were made for those who are advocating for change. But we have to also consider the potential harms. So for example, there may be less access to kidney donation. We're only going to approve candidate kidney donors who have really high kidney functions that's safe for them to do surgery. The GFR was artificially lowered, there may be less donors approved. The GFR will be lower, so there'd be different dosing, or maybe you couldn't even take some medications that are contraindicated in patients with low levels of GFR. And one common example is metformin, which is used for diabetes, and another common example used for diabetes and actually to prevent CKD progression is SGLT2 inhibitors, which you may have heard about. Their newer medications. But decreasing doses of antibiotics or pain medications and chemotherapy too. So the potential very wide implications. When we use for radiological images, we use contrast. And at low levels of GFR, we're not supposed to use it or supposed to use it very sparingly. And so we'd be more worried about that. And potentially some physicians would say, it's not worth the risk of doing this image, this radiological test, because of the risk of contrast. Potentially decrease access to life insurance or disability, the GFR is low. And overall is, and this is what I do worry about, is just more anxiety. More increased increased anxiety, increased labeling, and increased costs of medical care related to overdiagnosis of kidney disease. Next slide, please. And so what was the path forward? This was just a huge controversy. You know, everybody on either side had deep emotions because it was really important. It was an important question with a lot of implications. And so we're very fortunate in the kidney world where we had our two national kidney organizations, the National Kidney Foundation and the American Society of Nephrology, came together to say, let's have a task force that can thoughtfully address this really important question. Next slide. And I was very fortunate to be a member of the task force. Here you have all of us here. I want to call out our chairs, Neil Poe and Cynthia Delgado, who led us with wisdom and thoughtfulness and strength, but also in particular our, I'm sorry, the slide is missing our second patient representative, but you see Glenda Roberts here, who's one of our patients, and the slide is covering the other patient, Curtis Wakefield, who, and both of them together gave us such an important perspective on this complex problem. And altogether, all of the task force members brought together broad expertise, including health and healthcare disparities, epidemiology and healthcare research, genetic ancestry, clinical chemistry, patient safety and performance improvement, pharmacology, and social sciences. Next slide, please. So how did we take on this really big question? Well, under the wisdom of our chairs, we had a phase one where we really clarified the problem and evidence. And I won't read through all of those issues here, but we learned about GFR estimation and measurement, race and racism, laboratory issues, patient perspective, all of the really multifaceted issues that we needed to consider to address the problem. In phase two, we evaluated all alternative approaches alongside all of these criteria. And in phase three, we made recommendations. This took a long time. We had 2-hour sessions every week from August till May, including one Saturday virtual retreat. It was an intense part of my week. I had to miss other weekly meetings, but this became my own community where we together had over 40 sessions that we heard from 97 people from 21 states and 7 countries. We had 3 community forums where we listened to trainees, providers or patients, a written testimony from over 450 people. And we called for new science and an open invitation to make sure we had listened to the widest perspectives and the data that was not even yet published. Next slide, please. And so one of the questions we had to address is really thoughtfully attentive to the different approaches to leading to a way to estimate GFR accurately, but would not include race. And so, as I mentioned, the prevailing option at the time was to just drop race from reporting. But thoughtfully, we asked, well, okay, if we just drop the race, should we report the GFR that would have been for Black individuals, or should we report the GFR for non-Black individuals as the one number that's out in the laboratory reports? Or should we do both that? And that would be up for the provider to decide about which one will apply to individual patient. Or if we said, okay, let's just drop the race coefficient, which had, again, was the option was on the table at the time. And if we use an equation that requires specification of race and just ignore it, is that ignoring the contribution of the Black individuals to estimated GFR? And of course, there's this long history of using scientific results from whites for Blacks that we felt really strongly should not continue. And should the approach be unified? And from a patient perspective, will my GFR be the same if I move to a different healthcare provider or around the country? Next slide, please. And so we came together and we had a list of actually about 26 different approaches. And using all of that written testimony and the experts and the data, all of those, these are all factors that you see outside the circle, all of the different evidence that we reviewed. And we reviewed those along 6 different attributes, such as whether it can be reported by the laboratory, what's going to provide a fairly accurate estimate, what are the consequences for decision-making, what is the perspective of the patient. And we weighed all of these things. We actually weighed them individually. And so the fact that equation may be more accurate didn't have to weigh on the consequences, because we thought each of these are so important that we wanted to first look at each attribute separately and then come together for a final recommendation. Next slide. And so in the end, we recommended what is known as the CKD-EPI 2021 estimated GFR for creatinine. CKD-EPI stands for Chronic Kidney Disease Epidemiology Collaboration, and this happens to be my research group. So in parallel, I was doing work to develop an equation that did not include race, but combined all the information from everybody. And the reason that the task force, in my role, the task force, not my role as in my research group, the reason why the task force recommended it and why it was given all of those 6 attributes that I showed you is that it didn't include race in development, nor in the reporting. It was all the patients, we included a really diverse development population. Everybody contributed to the equation that you see. It was immediately available to all laboratories in the United States as a first-line test, so everybody could get it. There was acceptable performance characteristics in all groups, and the potential consequences did not disproportionately affect any one group of individuals. Next slide. So the next job that I had for our community was how to implement this equation in widespread practice and everywhere in the United States. So we're really fortunate to have the National Kidney Foundation to partner with us and to be prepared for this implementation right from day one. They've been working with the laboratory community, with the clinical chemistry community for several years now, and it's really primed to take on the implementation of the equation in all the United States. Next slide, please. And so my final message when I talk about this, I always share that I'm very proud of the nephrology community that we were able to come together and develop a recommendation for estimation of GFR without race that was based on really good evidence and really good data. However, the big problem we have in kidney health is racial disparities, and that these disparities are multifaceted. They're related to unemployment and food and housing insecurity, neighborhood issues, education, all exacerbated by racism. And I hope the GFR is the first step along the way. But I always conclude with there is much work to be done. Real change, enduring change happens one step at a time. Next.
Dr. Inker, thank you so much. Thank you for explaining the events that have occurred in the recent past. And it really sounds like the task force spent a lot of time deliberating and coming up with recommendations that put all patients first. Are you seeing that most labs and health systems have adopted the new equation?
Well, most is a big word, and implementation takes time. I mean, it's interesting. Even though I've been doing this for 18 years, implementing GFR, even in my own lab, I always am surprised at how long it takes. And I think it's good to recognize that this is a change and that needs to happen carefully. But there's been widespread acceptance of it, at least in the United States, where I think the problem was very well articulated even before we made our recommendations. So the last I heard from the Laboratory Engagement Committee, there's a whole long list of academic centers that have already implemented. I think LabCorp, one of the big laboratory service providers in the United States, has made a change. Quest, the other big one, is en route to doing that, I believe, in July. And then other ones are in process. So I actually think, given how difficult and slow implementation can be, I think there's been really fast acceptance and an eagerness to change.
Wonderful. Thank you so much. And again, appreciate your presentation. So Dr. Inker had mentioned cystatin C as a way to measure kidney function. And now we'll move on to Dr. Potok, who's done research on using cystatin C. And we look forward to the answer to the question, could you explain to the audience the advantages of using cystatin C as we move on to the future of testing?
Thank you for having me. I'm excited to be here. So yeah, as you already heard previously in this presentation, currently we're using serum creatinine to estimate kidney function, and creatinine is not a perfect marker. As it was said, you know, it's influenced by muscle mass and diet, and many other things. So there's another marker called cystatin C, which is a protein produced by all the cells in the body at a constant rate, and it's filtered by the kidney. And so it's another way to estimate kidney function. So there's a different equation using cystatin C to calculate estimated glomerular filtration rate, or EGFR, different from the one using creatinine. And I want to point out here that cystatin C is also not a perfect marker. It's influenced by different things than creatinine is, such as thyroid function, heart disease, smoking. If you're taking certain medications such as prednisone or steroids, it can influence the level of cystatin C. Having cancer, obesity can also influence cystatin C. So neither of them is a perfect marker, and both are estimations of GFR, and they remain estimations, which means they're not perfect. Next slide, please. Now, why are we working so hard to accurately estimate this GFR? Well, one thing is to obviously diagnose kidney disease and be able to potentially treat it. Next slide, please. The other thing is that most medications are eliminated by the kidneys, and so knowing what the kidney function is really important so that we can give you the appropriate dose of medications. For instance, antibiotics, most antibiotics are eliminated by the kidneys, and if you have a severe infection, we want to make sure that we give you the right dose to treat the infection. So you need, the proper dose. It shouldn't be lower than what you need to make sure the infection goes away. But at the same time, we want to make sure that we don't give you too high of a dose, which might become toxic. And so that's one of the reasons why, estimating kidney function is really important. Same thing with diabetes medicines. Dr. Anker mentioned SGLT2 inhibitors, which is a class of diabetes medicines that we can give you, and depending what your kidney function is, it is safe to give it to you or not. Pain medications, chemotherapy. If you have cancer, we want to make sure we give you the appropriate dose of chemotherapy to fight the cancer, but at the same time not being in a toxic range. And there are many more. These are just examples of medicines. Next slide, please. And so this is a review. This is to illustrate this. This is a group of researchers who did a review looking at the prediction of the renal elimination of drugs with cystatin C versus creatinine. Next slide, please. So they basically reviewed articles that were already published in the literature. They reviewed 28 articles that evaluated 16 different medicines in 3,455 participants. One of those medicines that came back often was vancomycin, which you might have heard of. It's an antibiotic that is given intravenously. It can actually be given orally as well, but intravenously we can check the level of vancomycin in the blood, and it helps us decide, what dose to give. And so overall, this review showed that cystatin eGFR was more predictive of drug levels and drug clearance than creatinine GFR. So this is kind of to make the point that cystatin, currently we're still using creatinine to dose medications, but perhaps we should consider using cystatin as well. Next slide, please. So what if the markers don't agree? It will happen to a significant number of people that when we check serum creatinine and serum cystatin C at the same time, we'll obtain different eGFRs by one or the other. And if these two don't agree, if they're widely different, then which one is the true kidney function? Then how do you know which one to trust? Next slide, please. Well, it kind of depends. It depends what your body habit is like. Here you have on the left Mrs. Jeanne Calment, who was a French elderly lady who here is having her birthday for her 121 years old birthday. And then on the other side, you have Arnold Schwarzenegger. I don't know anything about these people's kidney function, but what I can tell you is that given what we know on creatinine and cystatin C, I would expect people who are bodybuilders like Arnold Schwarzenegger to have a high serum creatinine because they have high muscle mass. And we know that muscle mass influences the creatinine level. And so this would lead to an estimated GFR based on creatinine that might be low and suggest kidney disease, while it's not necessarily true. And if you check a cystatin C, then perhaps you would get a different GFR. On the other side, you have a frail old lady who's, I would expect her serum creatinine to be low because her muscle mass is probably low. And so the GFR based on creatinine would probably be high, but this may not be because her kidney function is so good. It might just be because her muscle mass is low. And if you check a cystatin C, then perhaps you would get a different answer as far as estimated glomerular filtration rate. Next slide, please. So this is the actually the focus of my research. And we've been looking at the difference in EGFR by cystatin C minus by creatinine. And this is to show you in one of the studies we did this, looking at this difference and how many people had those various differences. So basically, if the GFR by cystatin and GFR by creatinine are the same, then the difference would be close to zero, right? If your GFR by cystatin is 60 and your GFR by creatinine is also 60, then the difference is zero. So kind of in the middle of this graph, you have zero. And then as you go away from the zero mark, one of the two markers is actually much higher than the other. Next slide, please. So we divided the population based on this difference, and we kind of arbitrarily decided if the difference is within 15 points, then let's say the two markers agree. But if they're different by more than 15 points, then one of them is significantly higher or lower than the other. And so as you can see, most people are in the middle here, within 15, having the GFR cystatin, the creatinine, sorry, the GFR by cystatin and the GFR by creatinine between 15 points from one from the other. And if you go towards the right-hand side, then you see that the cystatin GFR is higher by more than 15 points than the creatinine GFR. And towards the left on the red side, the cystatin GFR is lower than the creatinine GFR by 15 points or more. So our thought was that, Arnold Schwarzenegger's type of body habitus would be towards the green, and Jeanne Calment's would be towards the red. And next slide, please. We showed in several studies that those people in the red zone were at higher risk for frailty. Next slide. And also at higher risk of hospitalization, falls, cardiovascular disease, and mortality. Next slide, please. And so we wondered, is it all because of the muscle? Is it the muscle mass that explains that this difference is associated with frailty? And we actually looked at this in a study where participants had the creatinine and the cystatin that were measured, and also had some imaging of their muscles, either by DEXA scan or by CAT scan, and basically looking at the areas of muscles and how big they were. And we thought, maybe if we take into account the size of the muscles, then we could explain why this difference in EGFR is associated with frailty. And the answer is not completely straightforward. It sounds like, it looks like it does in parts, but it doesn't explain the entire association. Next slide, please. So my take-home points from this is that I think it is really helpful to check a cystatin C, if only to confirm the GFR by creatinine. And if they're, both giving you the same value for GFR, then great. This is probably close to what your actual kidney function is. There's also a combined equation, which we haven't talked about too much. There's an equation with creatinine itself, and then an equation with cystatin C itself, and then there's an equation that includes both. And it brings in data from both markers, and it may be more accurate on a population level. But if you know that one of the two markers is more accurate than the other, then the combined equation tends to lose information. And so I've now been looking at this in a study where we have measured GFR, which is what's called the gold standard. So we infuse a substance such as iohexol or iothalamate in a participant's venous stream, and then we measure the level at multiple time points, and it tells us what the clearance is, and so that's the actual measured GFR. And what we think is the true kidney function. And so looking at this and looking at those two estimates of GFR by cystatin and by creatinine in a population of older adults, it seems that the lower of the two GFRs is actually the closest to the true kidney function by measured GFR. But this, next slide, please, may not always be true. I told you if your muscle mass is really significant, then the serum creatinine will be high. The GFR by creatinine might be low, but this might not be the most accurate measure of kidney function. Next slide, please. So who should we screen and how should we screen? These are the conclusions from experts. The KDIGO guidelines are the guidelines that are followed by nephrologists in the US. And this is the KDIGO Controversies Conference, where the experts concluded that if you have high blood pressure or diabetes or any cardiovascular disease, such as a stroke or heart disease, then you should get screened for kidney disease. How do we screen? Well, we use both the eGFR that we just talked about and also looking for protein or albumin in the urine. You can have a normal kidney function based on the GFR, but if you have significant amount of protein in your urine, then you do have kidney disease as well. And as far as the eGFR, those experts concluded that we should check really both the creatinine and the cystatin C to assess eGFR. Next slide, please. I also just wanted to mention that we typically also do imaging because some kidney diseases are diagnosed with imaging. So this is a CAT scan showing you a person who has really big kidneys. Those two big darker portions are the kidneys, and those dark portions are cysts. So this is a polycystic kidney disease, and there's some clues when we check the lab work, but the diagnosis is really made by imaging. Next slide, please. And how about the risk of progression? So I put here a QR code that will take you to this website, the kidneyfailurerisk.com. Dr. Tengri came up with this equation about a decade ago, which is called the kidney failure risk equation, or KFRE, kidney failure risk equation, that you can actually have access to online if you go to this website. And basically, if you plug in your age, your gender, your glomerular filtration rate, or GFR, and albuminuria, so how much albumin or protein there is in the urine, with those two factors, this equation will give you an estimation of your risk of end-stage kidney disease, or basically being on dialysis, in 2 years and in 5 years. It gives you a percentage. Your risk of being on dialysis in 2 years is 5% or 15% or whatever it is. Next slide, please. And so we actually conducted this study in my institution, the University of California, San Diego, where we were interested to know how well this equation does. And so these three graphs basically look at predictions versus observed outcome. So in panel A here, we look at this KFRE, the kidney failure risk equation I just told you about, and what the prediction was from this. And we look at that against the actual outcome. So who actually ended up on dialysis 2 years later. And, you know, the better the predictor, the better this prediction will be aligned with the observed outcome. And so we looked at this KFRE, and then we asked the nephrologist, what do you think the risk for your patient is to be on dialysis in 2 years? And we also asked the patient, what do you think your risk of being on dialysis in 2 years is? And the nephrologist and the patients did not have access to the KFRE value. And these graphs show you, so the first one is the KFRE, second one is the nephrologist predictions, and third one is the patient's predictions. And these graphs show you that the KFRE was actually right on target. If you look at this diagonal line, you know, it shows you that the KFRE was actually able to predict what actually happened 2 years later and who ended up on dialysis. And so the higher KFRE score or KFRE estimation, the higher risk were to actually be on dialysis 2 years later. The physicians were pretty pessimistic, so they gave higher estimation of risk than what actually happened, and then the patients were a little bit all over the place. But the KFRE was really on target. Next slide, please. So I put the QR code here again, in case you missed it, the previous slide for this kidneyfailurerisk.com website. So this equation has been validated in more than 30 countries worldwide, and it's really you know, one of the most accurate and efficient way to determine what your risk is of being on dialysis in 2 years or 5 years. And you can have access to it yourself online. Next slide, please. And I just wanted to mention, we talk a lot about the GFR, which happens in the glomerulus part of the kidney. That's the filtering kind of unit of the kidney, but there are a lot of other parts in the kidneys that also, you know, contribute to kidney function. And one of them are the renal tubules where the urine is being made. And I just wanted to mention those biomarkers. You have a list here on the right-hand side that are being researched right now. And some of them are promising to be associated with kidney injury and progression of kidney disease. These for now are, you know, limited to research, and we don't have access to them in clinical practice, but hopefully in the next few years, you know, they'll develop some biomarkers that we can measure in clinical practice to determine tubular health and other portions of the kidney health. Thank you. That's all I have.
Dr. Potok, thank you so much. So for those of you who have been with us or just joining us, just a reminder, we'll start the question and answer portion very shortly. So you can put your questions or comments in the Facebook live stream or in the chat box if you're here with us on Kidney Action Week websites. So Dr. Potok, just a question for you. How easy is it to get a cystatin C test?
So it is run on standard analyzers. So I know it's available at Quest, and you know, it is pretty standard. But I think it is cost prohibitive for private pay patients, but otherwise it should be available.
And do you think that most individuals who are watching could get it from their primary care doctor or nephrologist?
I think so, yeah.
Great, thank you. Thank you both, Drs. Potok and Inker. So if we can just go to the next slide before we go into the questions and answers. Here are some resources that the American Kidney Fund has developed and can be helpful when navigating through kidney disease and in particular the transplant process. So these links will also be available in the chat. And now we're going to take questions from the audience, and they've been coming through on multiple formats. And so I'll be reading through these, and some are directed to specifically individuals who spoke, and some are just for us as a group of panelists. So I'm going to start out with one for Dr. Inker. So as a result of the equation modification to determine a more accurate eGFR, was CKD found to be more prominent in the general population?
So if you did the estimates, if you applied the new equation to, let's say, national surveys like NHANES, which I mentioned earlier, overall prevalence of kidney disease would be lower because the eGFR in the non-Black individuals be higher, and that would less likely lead to kidney disease, but it was more prevalent in the Black population.
Thank you. And now there's a couple of questions for me, Dr. Wright-Nunes. So they're kind of tied together, so I'll read them both together and then answer them. Are treatments available to those with early stages of kidney disease? Or do you have to wait at a later stage or when you need dialysis for treatments? And then if there are treatments, what are the medications that are available? Is there really any to stop or slow chronic kidney disease? So these are great questions. And there absolutely are things that we can do to optimize our health living with kidney disease in earlier stages. And some of those relate to the risk factors I spoke about that are modifiable, right? Not all of them are, but high blood pressure and diabetes, if a person were to have those, having those under as good of control as they can get with their primary care doctor are two really, really important things. We also have blood pressure medications, and some of them specifically called ACEs and ARBs, but that help us not only control our blood pressure, but have shown to slow kidney disease progression in certain types of kidney disease. And we've mentioned a couple of some of the newer agents, SGL2 inhibitors. I think that it's beyond the scope of this talk to talk about all the nuances and details, but I think they're really showing promising results in slowing progression. So these are things that we can do in earlier stages. There's also another question for Dr. Inker that came through. Will I see a change in how my eGFR appears on my lab results now?
That's a good question. I haven't looked at all the lab reports that will come out, and I don't know the language that's used in the particular value you're seeing. We've here at Tufts used eGFR creatinine. And so it looks, and we had a different label change for how our providers see it so they could differentiate from before. But for the patient perspective, which we now have in our patient portal, it would look the same. And I think that we're not trying to make people understand the past and have to really have all that knowledge in your head. It's helpful to know that the change, because although the change is not as big as I showed you in my talk, I went from example 61 to 53, be a smaller change. That's not a true change in GFR, but very soon we find that people accumulate enough blood tests, and so you can just look at that change from the change in the equation using, and that's the same. And that's the value that should be used. So I don't think you should pay too much attention to the difference, because the goal is more what is the level of kidney function and how to, exactly as the questions were asked earlier, what to do to prevent progression and to treat anything related to kidney disease and its complications.
Wonderful, thank you. So now I have a couple for Dr. Potok. The first one is, my doctor never talks to me about my kidney health. And do you have suggestions for how to ask about this when they seem so busy?
I think well, they're busy, but they're here for you. And if you have any concerns and questions, you should definitely raise your questions with them. I think asking them to explain your labs results and what your GFR is and what your kidney function is. I think they should be able to take the time and answer you and go over your labs results with you.
Thank you. That's great. I fully agree with you. And it's so hard on the patient side of things to feel empowered sometimes, right? But absolutely would advocate for that. Did you have anything to add, Dr. Inker?
Yes, I would. I think something that gets missed a lot is the importance of testing your urine. And so I think an important thing you could say is, can I have my urine tested to check my urine albumin to creatinine ratio, or ACR? That's something that often gets missed, and I think that would be really actually helpful for your doctor. I think it's okay to ask to see a nephrologist if you don't know. I think as a group, we're really happy to see people early in the disease course with any questions, and then we can work with your primary care doctor to see you once a year if necessary, or just to advise them, or what is required. And finally, I think there's a lot of education out there, and the more educated you are yourself, the more you can actually help your doctor to help you with your kidney disease.
Fully agree. Thank you. Thank you both. For Dr. Potok, with all of the new potential ways of calculating kidney function, how do I know which test is best for me?
That's a great question, and it's at an individual level that it's important. What I showed you here are data from studies and statistics, but for you yourself, I think you should discuss with your provider and potentially ask them about cystatin C to be checked, and discuss with them which marker is likely the most accurate, and as Dr. Inker mentioned, also check your urine and just ask your provider about all those tests.
Great, thank you. So here's a question for me. Why is it important to measure urine albumin? And as we had mentioned a few slides that I had and also just a little while ago when Dr. Inker mentioned it, albumin to creatinine ratio. So albumin is a protein, and it's a type of protein. And when that protein is high in your urine, it can signal damage inside the little filtering units of the kidney. And so that's why it's important, because it's not invasive. It can be done on a one-time urine test, so it doesn't hurt, and it's relatively easy to get done. So it's a good test to just check and see if there's evidence of kidney disease based on the urine. And so that's why it's important. The next question is for Dr. Inker, and it's a little bit related to some of the others, but does removing the race as a factor in the eGFR equation impact current estimates of all individuals that have kidney disease, and how so?
So for people who had been identified as a Black person, then their GFR value would go down. And it changes a little bit based on your age. So the greater impact at lower age when you're younger, and at lower levels of creatinine, so higher levels of GFR. There's a much bigger difference than at higher levels of creatinine in older age. And the converse is true for people who are not identified as Black individuals, that the GFR go up. But again, it's a bigger impact as for younger people and with higher levels of GFR or lower levels of creatinine. So in the vast majority of people who have in the kidney disease range, the change is small. When you look at it all together, as I mentioned earlier, it would change the overall prevalence of kidney disease. But for most people, they're not going to see a change in their GFR category or their CKD stage.
Excellent, thank you. And one last question for me. I have diabetic kidney disease, and my mother had diabetes, but doesn't recall having tests to see if she has had kidney disease. Should I encourage her to get tested? I think you're going to see all of us nodding emphatically, all of the panelists, that yes. And as we've already described, even just a simple urine test can get started. So absolutely, and great question. So I know that time goes fast when we're sharing all of this great information and the wonderful questions that have come through. I want to thank you all for participating today. There was a lot of really valuable information that was shared. And I'd like to ask the panelists to sum up a couple of things, one or two things that they think are important to know about kidney disease testing that they'd recommend doing when it comes to advocating for themselves as patients. And I was asked to start to be the first one. So my one or two things are that, first of all, being aware that kidney disease is out there and that it impacts a lot of individuals, but feel empowered to work with your primary care doctor, certainly if you have the risk factors, and even if you don't, to ask about it. I also think that taking advantage of the American Kidney Fund and the wonderful resources that they've developed with patients and providers and advocates is really something that I feel like AKF can be proud of, and the patients who gave input into these materials can be proud of. And I use them as a resource all the time with my patients. So I hope that you would find them valuable as well. So those are my two things that I'd recommend. And I'll go next to Dr. Inker and then Dr. Potok.
I agree completely. I think being aware and actually being here today is the first step. And I think it's okay to ask a question. Your doctor is busy, absolutely. And there's actually a lot of things that she wants to take care of for you. But asking questions is the only way to move forward. And asking about having a urine test to measure the ACR and a blood test to measure the GFR are two big factors. We talked about some complicated things today, but it's okay. You don't have to know all of that. All you can say is, what's my ACR and what's my GFR? And your doctor will do the job of figuring out all of the various things we talked about, or asking for help from a nephrologist. We're all happy to see you.
Fully agree, and thank you. And Dr. Potok?
I fully agree with you both, and I don't have much to add, but yeah, definitely, I think you can ask your providers to check GFR with creatinine and cystatin, and also always check urine, and don't be intimidated to ask questions. The provider is here to help you, and if you have concerns, you shouldn't hesitate to ask questions.
Wonderful. Well, Drs. Inker and Potok, thank you so much again for spending this time with us today, providing your expertise on kidney disease and testing. And clearly so much continues to evolve, and it's exciting to hear about the latest research in these areas and what can impact the future of testing. So thanks for everyone tuning in today. We hope this was informative and that you had a chance to ask your questions. Next on the agenda is a session on APOL1 mediated kidney disease at 4 p.m. And if you aren't already, follow us on Facebook or send us your email through kidneyfund.org, and you'll be the first to know about other resources like this. And also make sure you check out the agenda for the rest of this Kidney Action Week. Once we conclude the session, you will see a poll for a quick survey pop up. And so please take a minute just to fill it out. Tell us how we did. Your feedback will be very useful as we plan our future sessions. Thanks, everyone, and have a great day.